Good evening and welcome to Reproaction's Act and Learn webinar. We're very excited. Tonight our topic is demystifying abortion. So first we'll get started by introducing your hosts. The first voice you hear is me, Erin Masson. I'm based in Arlington, Virginia, right outside of Washington, D.C. I am one of the co-founders and co-directors of Reproaction.
And this is Pamela Merritt. I am the other co-founder and co-director of Reproaction, and I'm based in St. Louis, Missouri.
So a quick rundown of the agenda for tonight. First, we'll introduce Reproaction. Who is this organization? What are we all about? We'll introduce the topic of demystifying abortion and why it's important for us to have this discussion tonight. We're very excited to go through an Abortion 101 discussion with Selena Adetunji, who is one of the co-founders of Access Reproductive Care Southeast. It's going to be an awesome discussion. We'll briefly touch on next steps, and then we'll open it up for Q&A. So tonight, if you have any questions, the way that we'll moderate questions is by putting them in the chat box. Feel free to chat in your questions at any point during the question. At any point during the evening, we'll get to as many of them as possible at the very end of the presentation. The second thing I'd like to do is encourage you not only to send in questions, but also to live tweet as you see fit. We use the hashtag Reproaction. So very briefly, Reproaction is a new direct action group forming to increase access to abortion and advance reproductive justice. We're incredibly proud of our left flank analysis. We have a willingness to hold folks on all sides of the issue accountable, whether they are allies or opposition. We believe everyone must be held accountable to increasing access to abortion and advancing reproductive justice. And we have a proud, deep commitment to nonviolent direct action. With that, I'll pass it to Pamela.
Thanks, Erin. So one of the reasons we're talking about demystifying abortion today is that of incorrect misinformation that's floating out, particularly in the media and in other areas. So we just want to make it clear that abortion is a common and safe procedure. The misinformation is everywhere. Deliberate lying from abortion opponents, abortion stigma means that frank discussion is hard to find even without the deliberate interference of abortion opponents. And bad reporting by the media is more often the rule than the exception. And so with that, I'd like to turn it over to Kebe, who is going to go into this in greater detail. Kebe? Kebe, are you there?
Yes, I'm here. Sorry, I was muted. So thanks, Pamela. I am a fairly young person, and in talking to my friends, a lot of us were never taught how abortion works and don't even really know that much about conception. You know, we have a general idea that an egg is fertilized, but that's about it. And in my own public education, sex ed was maybe 2 classes of abstinence-based. If you don't have sex, you won't get pregnant or contract an STI. And my mom was an HIV/AIDS community health educator at the time, so I knew that some of the information that I was receiving was medically inaccurate even then. And if you think you might be pregnant, or you're sure you're pregnant and you're looking for more information, if you're wondering about ending the pregnancy and where to search online, something like how abortions are performed or what is abortion, a lot of the top hits that come up are going to be videos or websites containing deliberately medically inaccurate and shaming information that's being disseminated as a pro-life tactic to sway your decision whether or not to seek abortion care. And in addition to this, media representations of abortion are also often inaccurate. We know that earlier this year, Media Matters for America, which is a web-based nonprofit whose mission is to monitor, analyze, and correct conservative misinformation in U.S. media, published a 14-month-long study So this was on evening cable news programs, and it found that discussions of abortion were weighted toward anti-choice speakers, resulting in widespread misinformation on the subjects. And just to give you a sense and highlight some of those findings, Fox News aired 705 statements containing inaccurate abortion-related information. 40% of all appearances on all three networks in the study, Fox News, CNN, MSNBC, were made by people who either identify as anti-choice or who consistently or mostly made anti-choice statements. And this is compared to only 17% of all appearances on all three networks made by people who either identify as pro-choice or consistently or mostly made pro-choice statements. Finally, CNN had 3 times the number of anti-choice guest appearances as pro-choice. And in addition to this inaccurate reporting, we also know that there are thousands of crisis pregnancy centers in this country that advertise themselves with lines like pregnant, scared, call this number, or unplanned pregnancy, free confidential information. And these are places that give false information to people like abortion causes breast cancer, or abortion causes infertility, or permanent clinical psychological damage. And we know that many states have passed laws that mandate that this kind of medically inaccurate information must be given to patients before they can have an abortion. So we're hosting this webinar on demystifying abortion because we get pregnant, and sometimes we can't or won't carry those pregnancies to term. And we deserve real health education, especially education about abortion that is so crucial in determining when and whether we choose to give birth, to parent, and create families. This webinar is also important to us at Reproaction because it serves as a knowledge share to provide medically accurate information for anyone who is considering having an abortion or is just interested in this information. And this can be activists or advocates who want to know more about the procedures for their work, or patients or friends or family who might want to support someone who they know is considering an abortion with accurate information. We also think it's important to reflect that sometimes we end pregnancies that we may have otherwise expected to have gone to term, and sometimes we have non-viable pregnancies or tubal pregnancies or experience spontaneous pregnancy loss. And this webinar is going to focus on abortion to end a pregnancy, but we recognize that people's experiences of pregnancy loss, of abortion and birth are really complicated and varied, even amidst so much misinformation and shaming and stigma thrown into the mix. So we support you in whatever is right for you. We celebrate legal, accessible, and funded abortion as a great thing. We embrace sex and sexuality. And we know that people of all genders, women, trans folks, and people who are gender nonconforming must be able to have sex and become parents on their own terms if they are ever going to enjoy political, social, and economic equality. So with that, I will pass things off to Selena Adetunji. We're going to start our Q&A here, and she's here with us today to break down what someone can expect if they are having an abortion. Selena is co-founder and a board member with Access Reproductive Care Southeast, based in Atlanta. She has been working on reproductive health and justice issues for over 12 years, and her specific area of expertise is with abortion care and research. She has worked with people of color addressing reproductive justice issues, including HIV and STI prevention, adolescent pregnancy, contraception, abortion, sex work, and transgender healthcare. So thanks so much, Selena, for your work. It's so important, and we really appreciate you breaking things down for us today.
Well, thank you, Kebe. This is an absolute honor to have a space where I can actually really sort of take the time out and explain in detail what the true facts are, and have a place where I can explain myself in terms of like my education and what it is that what happens in the clinical setting and how people are cared for in terms of seeking abortion. Thank you.
Yeah, absolutely. So to start off with your Abortion 101, let's begin at the beginning. How does pregnancy begin?
So I chose this diagram and explaining how pregnancy begins is because I like this one is because when you actually look at where it's down there where it says day 8 and 9 from when the oocytes or when the egg is released from the ovary, that's actually where pregnancy begins. So all those things that happen, all those steps that happen all those days before going from the oocyte to day 0 all the way to day 7 are actually non-viable pregnancies. It's only considered a pregnancy when the fertilized egg actually implants in the wall of the uterus. What happens is there is a shell that is around that fertilized egg that actually participates in the fusing with the wall of the uterus, and it releases a hormone, and it's called the HCG hormone. And that usually, when that happens, that actually is what really shows up in a pregnancy test to indicate that the person is officially pregnant. So if a person does engage in sexual activity and that egg is fertilized as a result of that sexual act, the thing is that that egg or that oocyte or that fertilized egg can actually terminate or die on its own between day 0 and day 7, and that person never have a positive pregnancy test. So when you hear things coming from the anti-choice rhetoric about, sorry about the noise, coming from the anti-choice groups stating that, you know, pregnancy begins at conception, it really does not. I want to be very, very clear about that because conception does not guarantee that the fertilized egg is actually going to implant in the wall of the uterus and that pregnancy is guaranteed.
All right, thanks for that. And to move a little bit further, so how does a doctor know for sure, you know, that I'm pregnant and then determine how far along the pregnancy is after the egg is implanted?
Yeah, so we just talked about that for a second. And so that fertilized egg is called a blastocyst, and that is what breaks free from the shell, and it's ready to actually stick to the wall of the uterus, which is the endometrium. And then what happens is once those two things combine, that's when you get the human chorionic gonadotropin hormone, or HCG, that indicates that you're pregnant. That is going to show up as early as 28 days after your last normal menstrual period in a home pregnancy test. You can also go to the doctor and they can actually test for a specific amount being in your system through what they call a beta HCG test. Keep in mind that this hormone is only present in the most earliest stages of your pregnancy. Once you actually reach your second trimester, the HCG hormone goes away. So sometimes what happens is some people could be pregnant and experience some bleeding throughout that pregnancy, and then it goes away. But if they're not visibly pregnant and they're not too sure, they can actually go to the doctor, get a blood test, and this hormone not show up because they've entered into another trimester where the hormone is no longer detectable. So that's why you have the ultrasound or the sonogram for people who are much further along to indicate that they're pregnant if they don't have any sort of obvious symptoms such as their period has stopped or they have a negative pregnancy test, because some people can be upwards of 17 weeks pregnant. So you have the ultrasound to also function as a way of indicating if someone is truly, truly pregnant if these tests come back negative. The blood test and the urine test, to be specific. The other way is that, you know, trust your body, trust yourself. You know yourself very, very well. So some people also will determine their pregnancy based on their last normal menstrual period and because they didn't have a period going forward after that. So that's another way, you know, listening to your body, knowing your symptoms, knowing that you're having symptoms of pregnancy, and then also looking at the calendar from your last normal menstrual period, you can also make an estimation as to how far along you are in that pregnancy.
Awesome. So then once I know that I am definitely pregnant and I have decided to terminate the pregnancy, I've decided to have an abortion, how does the provider determine what procedure is right for me?
So I actually thought this was an interesting question, and I want to make it very clear to all the listeners that are hearing this question here. What procedure is right for me? When you're actually 10 weeks pregnant and you're pregnant, less than 10 weeks pregnant, you determine which procedure is right for you. It is not up to your provider to determine what works for you. The most common procedures that are offered are for people who are under 10 weeks into their pregnancy is the medication abortion and the aspiration abortion. I listed here specifically what the technical names are, because if you actually Google these words, you're going to find out that the anti-choice people have basically taken over these words in order for you to go down this line of misinformation that sort of feeds into whatever propaganda that they have in terms of abortion being harmful. So I wanted to make sure that I kept very clear to the very technical words that are used in terms of that. So depending upon how far along you are, you can have a medication abortion up to 10 weeks into your pregnancy. You can have an aspiration abortion to up to anywhere from 14 to 16 weeks into the pregnancy. Keeping in mind that most abortions occur, 89% of abortions occur within the first 12 weeks of pregnancy. There are other circumstances that lead to more that lead people to needing what they call a dilation and evacuation, which is a little bit more different. So medication abortion is the termination of pregnancy using one or more of the following medications. People typically use mifepristone, which is a pill that you take in the office in order to end the development of the pregnancy. Sometimes you can take methotrexate, but that is not commonly used anymore. And then you'll take some pills at home called misoprostol, also known as Cytotec. That is going to actually cause a chemical induction of a miscarriage, and you will actually start to bleed, and that will cause you to expel the pregnancy on your own. Common names for the medication abortion is RU486. Some people call it the abortion pill. Some people call it medication abortion. So those are some of the more common names for that. For most people who are seeking a surgical abortion, you can have what they call is an aspiration abortion. Aspiration abortions are mostly done while people are awake, but sometimes if you have a clinic that has a capability, you can actually be put to sleep in order to reduce the pain and discomfort that is sometimes associated with aspiration abortion, but most people are awake. This procedure terminates the pregnancy by using a manual or electric suction device to empty the uterus, and it usually takes anywhere from 2 to 5 minutes for that to occur. Sometimes people call the machine the manual the electric vacuum aspirator, or sometimes they'll call it a manual vacuum aspiration device, which has no electricity. The NVA is commonly used in countries that have no electricity that are providing abortion care for people, and also the NVA is used for a lot of other providers for miscarriage management. It was originally invented for that, actually. So keep in mind that when people are having miscarriages, one of the medications in the medication abortion, misoprostol, is used to help people finish up their miscarriage so they don't continue to bleed excessively, as well as the aspiration abortion is utilized for people who are also having miscarriages. Dilation evacuation is something that is typically used for about 9% of people who are seeking abortions beyond 14 weeks into their pregnancy. And what you normally have to do is a twofold process. So dilation is something that you have to go in, and they'll take these small sticks that are made out of algae, or some people call it seaweed, and they're placed inside of the cervix, and they absorb the moisture around the cervix for a period of 12 to 24 hours. The person will come back in the next day, and then they will have those dilators removed, and then with a very small set of forceps that are about maybe an inch or inch and a half long, they will use those in order to remove the pregnancy tissue from the body, or the pregnancy from the body. And that's why it's called dilation evacuation, because on day 1 you have dilation, and on day 2 you evacuate the uterus in order for it to terminate the pregnancy. So and this is also commonly used for people who have fetal anomalies. Most people don't know that they are diagnosed with certain fetal anomalies until 14 to 20 weeks into their pregnancy, so they will have to present in the clinic if they choose to end the pregnancy with a dilation and evacuation. And if someone has what they call a fetal death, which means that they end up having a miscarriage in the second trimester, you will have to proceed to empty the uterus with the fetus that has died. You would have to utilize the D&E method in order for you to actually empty the uterus so that there won't be any ongoing complications with that person's condition. So one of the things I just wanted to just kind of emphasize is that abortion care is family planning care. And all these methods that are utilized for people seeking abortions for undesired pregnancies also used for miscarriage management and also for people who have special circumstances like fetal anomalies. What can a patient expect in each procedure? It really varies what people can expect depending upon your health history, your pain tolerance, how many previous pregnancies you've had, the type of procedure you're looking at here between the medication aspiration or the dilation and evacuation, and what sort of medications are actually given inside the clinic before your procedure and after your procedure will really determine exactly what the outcome is. I really do spend a lot of time asking doctors and providers what that is, and then try and get a sense of people's anxiety and people's concerns and people's health history to determine the best course of action for that person and let them pick from the list of choices that are available. Going down to, are there any risks associated with these procedures, and if so, what are they? So one of the things I always assure people is that this is a very common procedure and this is a very safe procedure. All three of them are, no matter how far along you are in a pregnancy. And keep in mind that less than 3% of patients who have abortions experience complications, and most of those complications can be treated in the clinic before the person is released from their care in the clinic.
Got you. So with some of those complications, or even just side effects, what are some of the common side effects for someone who has had a medication abortion or one of the other procedures that you have just described?
That is a good question. Keep in mind that it is actually the misoprostol that is given to start the abortion on your own. That's the second medication that you're given with a medication abortion to expel the pregnancy. There are side effects. Some people experience them, some people don't. But to let you know what they are with full transparency, the most common is nausea. Some people do experience vomiting, and that's why some clinics will tell you to actually take the misoprostol pills and put them in your vagina. Because if you've actually had nausea and vomiting throughout your pregnancy, you don't want to put the pills in your mouth and let them dissolve and potentially spit out the medication and it not take full effect. So there is a lot of providers that will suggest that you take misoprostol by putting it in your vagina to allow it to take full effect, because the nausea is very, very common side effect to the misoprostol. Keep in mind, misoprostol is, it has hydrogenated castor oil in it. So it does sometimes cause diarrhea. So that is another side effect. And the other more or less common side effect to taking misoprostol with a medication abortion is shaking. Some people get really freaked out because the medication misoprostol causes the smooth muscle to react very strongly. And the smooth muscle could be your heart, so you feel like your heart's having palpitation, and you can cause your arms and your legs to shake because it's actually pressing your uterus together really tightly to try and push the pregnancy out, as well as opening up your cervix at the same time. So it's one of those medications that has some side effects like that. So we always recommend that if you're going to do the medication abortion, have a support person with you to keep you warm, to make sure you have a bathroom that you can go to, so that if you do get diarrhea, that you're prepared for that and prepare for the bleeding. So keep in mind that that is a common side effect to the medication abortion is nausea, vomiting, diarrhea, and sometimes shaking.
Okay, and while we're there, I just was wondering, so do most people have medication abortions who have them at home in home settings?
Yeah, that's the whole point of it. It's sort of like the DIY of abortion. You know, like you go into the clinic Some people don't want anything, don't like the instrumentation process of of aspiration abortion, and they don't like the some of the risk or some of the complications that are listed here in terms of cervical tear or perforation of the uterus, or sometimes people are really, really concerned about those things. The medication abortion allows you to have control over your own experience. It allows you to have privacy in your experience as well. So that's really the benefits of doing it that way. So that's one of the reasons why it's available to people, because it's not a provider controlling when you choose to start your abortion. It's you putting the pill in your mouth. It's you putting the pills in your vagina and starting this process on your own and ending this pregnancy on your own.
Got you, and maybe hopefully with the support of another person beside you. And so you talked about some of the side effects with a medication abortion. What about with aspiration?
I would say the most common side effect with that is the cramping that comes afterwards, because once you actually break the sac of the embryo in the pregnancy with an aspiration abortion, the uterus actually pulls back really tight very fast. It can happen immediately, like unless it could be visible within less than a second. And sometimes it could be a gradual process where some people will feel it up to about 15 or 20 minutes after the procedure. They was like, oh, I didn't feel anything. And then eventually the muscle is going to actually kick in, because two things are happening. One is that your vessels are opening up progressively with every week of the pregnancy as it grows, in order to kind of give it more nutrients through blood flow. And then actually the uterus is expanding. So when the embryo breaks, it's a sudden reaction with the body, and the body's like, okay, there's this empty space, it's time for me to pull it back in. So cramping is a very common side effect with the aspiration abortion, as well as with the D&E procedure as well. It may happen a little bit slower, but it's still a very common side effect. And the other side effect is nausea. The cervix is very sensitive when you're pregnant. So what happens is, because you have to place the tube inside the cervix in order for you to do the aspiration abortion, and then there's also the same process that happens during the D&E, the cervical manipulation sometimes causes people to be nauseated after the surgery, or after the procedure, excuse me.
Got you. And then, with both of these procedures, is there anything that you should be looking out for after you have them, maybe in the following days or weeks?
Absolutely. Every single clinic has a list of precautions or reasons to give them a call if you suspect that you're having some sort of severe side effect, or if you think that you're having a complication. And the best thing to do at that point is really just listen to your body. Typically, the National Abortion Federation sets guidelines in terms of reasons for you to call back your clinic for having concerns, and that could be having signs of an infection. Usually that is having a fever of 100.4 or higher. Sometimes people get cold sweats and fever chills along with those symptoms, followed by a foul-smelling discharge. The other thing you should look out for is your bleeding profile. You should have some bleeding as a result of having a medication abortion, but the heaviest should occur during the cramping as you are expelling the pregnancy. But if you find yourself getting to the point where you have gone more than 6 hours with soaking more than a pad in an hour, and also after having an aspiration abortion, soaking more than a pad in an hour, it is certainly a reason to call back your provider to have yourself checked out in terms of you having excessive bleeding. The other thing I always warn people about is it's called post-abortal syndrome. That's the technical word for it, but that really means retained tissue, so an incomplete abortion. A lot of times it doesn't show up as really hard, heavy cramping. Most of the time they can actually catch these symptoms inside of the clinic, but if they can't, sometimes you'll have this weird pain that will be radiating down one arm, or it'll radiate down one leg, to the point that you feel like you can't walk. So sometimes you would need to actually go back to the clinic and make sure that you don't have a retained tissue, or if there's a blood clot that sometimes forms inside of the uterus that can also cause severe cramping. And these are very rare. This falls into less than 3% of complications that happen after surgery.
Wow, okay. So now that you have kind of broken these procedures down and let us know what we should be looking for and what we should expect in them, I was wondering if you could touch on any frequently asked questions. So things, I know you've been doing this work for 12 years, things that come up in counseling or supporting others.
Yeah, these are the ones I felt like I see the most. Like, does it hurt? Like both for all three. Like I hear that all the time. Does it hurt? I was like, and so one of the things I try and remind people of, depending upon how far along they are and depending upon what procedure that they're having done, I call it I will explain to that person step by step, like, you know, this person's going to place a speculum in your vagina while you're awake, and this is what they're going to do, and this is what you should expect to feel, and then this is what is, because if you are awake for your abortion, and it's an aspiration abortion especially, it could be very sensational. It doesn't mean that it exactly hurts. It's just like, you've never really had anyone dig in that area like that before. It's very awkward. So sort of just stepping through that process and reminding people that probably the most uncomfortable part is either if they put an IV in and it's time and you want to go to sleep, or it may be uncomfortable to have the speculum placed in the vagina when you're awake and you're nervous. So it really varies from person to person in terms of what really hurts. And also because there are a variety of sedation options of you being very awake versus being very asleep, you know, pain sort of shows up in different areas. And I do also assure people, everyone has cramping at the end. Everyone cramps at the end. You have to cramp at the end. It is a true sign of good recovery. If you're not cramping, then that's not good. That means the vessels are not closing down, the uterus is not shutting down, it's not trying to return back to its normal size. So actually, pain is a good thing. Pain is a sign of healing. It's a sign that your body acknowledges that it's no longer pregnant and that you're less likely to have heavy bleeding once you get released from the clinic. Everybody always asks, can I get pregnant again? And I'm going to say it right now, and I cannot stress this any harder. Once you end a pregnancy, the body loses its chill in terms of like, I want to get pregnant again. I just interrupted a cycle. So what happens is sometimes you can actually ovulate the day of your abortion, but some people actually ovulate somewhere between the day of their abortion and 14 days after their abortion. And so if you keep that in mind, if you only have a 1 week restriction in terms of preventing infection and not putting anything in the vagina, if you have sex on day 8 and you ovulated on day 7 of your recovery but didn't have sex, you can get pregnant again. You can get pregnant again very quickly after an abortion. Because nothing that is going on in terms of abortion affects your ovulation. It does not affect your ovaries. Once the uterus is clear, an egg can come out, it can be fertilized again, and it can implant again because there's space and opportunity. So do not make any assumptions because you're having unpredictable bleeding from a medication abortion, an aspiration abortion, or a D&E that you can't get pregnant again. You are clearly ovulating. It's just unpredictable bleeding from the procedure in addition to your menstrual cycle trying to reestablish itself. So I always tell people after an abortion, you have to take the most extreme precautions in terms of not getting pregnant again because you're most likely to become pregnant shortly after an abortion. Bleeding varies from person to person. You're going to bleed longer with a medication abortion because it really does mimic a miscarriage. So you can bleed for as little as 2 to 4 weeks. And then depending upon how your provider takes care of you at the end of your aspiration abortion or your D&E, you can bleed for as little as 3 days, but most of the time people bleed for 1 to 2 weeks after an abortion. Infection is very, very low because most clinics use sterilized instruments or single-use instruments in order to prevent infection. And as long as you don't put anything in the vagina like tampons or douching or actually sitting in a body of water like swimming or taking a bath, you significantly reduce your infection. And if you don't show any signs of infection within the first 3 days after your abortion is complete, it is highly unlikely that you're going to get an infection. And infection rates are less than 1%. We've already talked about taking a bath. Wait 1 week. And if you really feel like you need to take a bath, only put you and the water in the bathtub. Do not put salts or perfumes or anything like that. You want to make sure that the water is mimicking your body chemistry as much as possible. So you can fill up the bathtub after 1 week of surgery or a medication abortion. You can fill up the tub with water, but only you and the water can be in the tub. Do not add anything else into the water, and you won't get infection. Some people ask me, what does it look like when it comes out? I do spend time with people who are having medication abortions to describe to them what it looks like when it comes out, so they just know what to expect, because they are doing this on their own. It does not look like a regular period. There is, you will see some tissue from the sac. You will not see the embryo because the embryo is smaller than an eraser tip, so it's not that big. But the other components of the pregnancy, like the chorionic villi, which kind of looks fuzzy, and the sac kind of looks grayish and a little bit pinkish in color, and then there's also blood clots. So I do let people know when they're having a medication abortion, do expect it to be blood clots, blood, and also some tissue, and I do describe that tissue to them. If people are having an aspiration abortion or a D&E, I am really honest about what it looks like when it comes out. I think that it's your body, this is your choice. This is information that is important to you. So I do take time out to describe what it looks like based on how far along they are. And it can vary. So if you're having a D&E, or excuse me, a dilation and evacuation at 14 weeks, it's a different description than someone who's having it at 20 weeks. I did work in a clinic where I actually did show people their fetuses. I had no problems doing that. It came from your body. It's no different than you asking your doctor, like, can I see my teeth when you have it taken out? Can I see my tumor if you had one removed or a cyst removed? You have a right to see those things. That's a part of you. You are a part of that experience. You made a decision about how you wanted to navigate that part of your life. So I am definitely one of those people that was okay showing people's fetuses to them, and people were fine. It actually brought a lot of people a lot of closure, and it actually helped them see something that actually helped them get an idea of what was going on with their bodies and what happened, and not sort of go off of those graphic and ridiculous pictures that the anti-choice people have crafted in terms of what dead fetuses look like, because those are very inaccurate, and a lot of times some fetus that looks like it's 6 weeks is really one that actually is 12 weeks. So they always give you the wrong image for the wrong gestation. So that always annoys me. And the last question, how do I know it's done? The medication abortion one is probably the most common time I actually get that question. It's like, how do we know when it's done? Like, you start bleeding, and then when does it stop? You will feel an instantaneous sense of relief, because that cramping will suddenly just come to an end, and the bleeding will suddenly just die down. Like, it really just calms down. It gets really intense, and then you will experience the expelling of the pregnancy, like a miscarriage, and then it just suddenly stops, and all you have is this minor cramping. There's a very significant change in your discomfort and side effects, so that's how you know absolutely it's done.
Wow, so that was really, really, really helpful. So we are going to move on to the resources. Do you want to kind of touch on these resources that you provided us for more information?
Yeah, so I encourage people, if you have questions, please call our health line, and extension 3 is for information and resources. I generally answer extension 3, or if we have any other people working on the health line, they'll be more than happy to answer any questions, especially if for people who are seeking abortion services, or people who are in need of more information in terms of family planning or contraception resources. I also encourage, everyone that's listening today to please go to the National Abortion Federation website. They do a lot of amazing work in terms of making sure that they regulate a lot of clinics around the nation, in Canada and the United States. Also, they have publications through their Society of Family Planning in terms of a specific abortion research, and they also have other things in terms of policy-related work that they also engage in regards to addressing abortion issues. But they really do have a lot of resources on their website in terms of addressing basic questions about abortion, also people who are seeking abortion care. Backline is an organization that I have been working with since the first day I worked in the clinic. I love these people because now they have opened up an all pregnancy option center. That means that they are kind of under the umbrella of like crisis pregnancy centers, but they're offering all options to people. And they have a wonderfully trained staff on their backline that are able to address any questions or any concerns in terms of people helping themselves make the decision and also helping people cope with their decisions. They also support people who identify as men that may need support, family members that need support. They actually even support health workers that do abortion work so that we actually have a place to talk about our experiences as we sort of absorb a lot of those very heavy stories inside of the clinical setting. So Backline, hands down, that is, I feel like Backline's for everybody. Bedsider is a very good organization that actually comes out with really cool infographics and also up-to-date information in terms of family planning options like contraception and abortion. And I really feel like they're very progressive in terms of what they do things. Guttmacher is a research institute that's been around for over 30 years, and they do abortion research all over the nation. So if you live in a particular state and you just want to know about abortion in your state and how to access it and what does that look like, what does contraception look like, what does adolescent pregnancy look like, anything that's really involved in sexual and reproductive health, Guttmacher is a really good website to go to in order for you to get some hands-down local information in terms of your state, but also to get some really good national level information as well. So they're a very reliable source. And a lot of us who have been educated in the abortion arena have always rested on the knowledge and research of Guttmacher.
Got you. Well, I am right now in awe of your knowledge and how you have all this information and how you do the work of sharing it with folks who are, seeking abortion care. I am going to, I guess, pass it off now. Thank you, Selena, to Erin, who can facilitate our audience Q&A portion.
Thank you, Kebe. I appreciate it.
Thank you, Selena, and thank you, Kebe. That was an incredible wealth of frank, honest, open information in an area where there is so much mystification. So I want to encourage anyone who has questions to chat them into the chat box right now in the questions box if you have them for Selena. Before we do that, I also want to encourage anyone who's watching to be sure to be plugged into Reproaction's work. Sign up for our email alerts at www.reproaction.org. That way you won't miss a single thing. We'll be sending out a recording of this excellent webinar in a few days. Also, please follow us on social media, where we'll also be sharing a recording of this webinar in the coming days. We are Reproaction on Facebook, Twitter, and Instagram. And then I'd also like to encourage you all to save the date for our next Act and Learn webinar. It will take place on Thursday, September 27th at 7 p.m. Eastern. And our topic next month is going to be body image and sexuality. So we're really looking forward to diving into that topic as well. Please do save the date. We'll send out invitations if you follow us on email or follow us on social media. Email, you certainly won't miss it then. And feel free to send us topic suggestions as well anytime. We conduct these Act and Learn webinars every single month with the goal of connecting activists from around the country, sharing information, sharing what works, what doesn't, and exploring topics in greater depth. So with that, I'm going to pass it on to Pamela to moderate any questions that folks may have.
Thank you very much, Erin, and we do have questions. So the first question is from Paula. Paula is in an area where HB2 closed down an abortion clinic and has heard stories of self-induced abortions and complications. Women in Paula's community want to know if they have a self-induced abortion and seek help, can they get in trouble with the law? Selena?
Yes and no. So it just depends in terms of what's going on. And I really did follow the HB2 bill all the way to the Supreme Court. It caused me to move all the way across the country to come to the South in order to better support people in terms of accessing abortion. And so there is no real way for anyone to actually figure out if you actually started the abortion on your own or not. Keep in mind, especially in Texas, one of the biggest street drugs that's out there is illegal misoprostol. Misoprostol, and I'm going to always keep to that name. The brand name is also called Cytotec. If you look up Cytotec online, it's going to tell you it's an ulcer medication, and one of its warnings is do not take if you're pregnant. It really is truly used to actually treat ulcers. So you can actually go to other countries, especially across the border, and get this medication and say, my stomach hurt, me duele, whatever. You can do whatever you want, but you can get your hands on misoprostol in order to treat another condition and then use it in order for you to induce an abortion on your own. The problem with taking misoprostol illegally and not knowing exactly how that medication works is you're more likely to have a retained tissue problem. And then you will present with excessive bleeding and cramping and possibly some symptoms of infection in the emergency room or possibly at an abortion clinic at that time. Nobody at any abortion clinic that I know of is going to call on any authorities in terms of you starting the process, as much as those people in those clinics want to know the truth so that they can actually create a plan of action to make sure that you don't increase your risk of infection, that you don't continue to have excessive blood loss that will lead to the need of a transfusion, and will not continue to the point that you would need any other intervention that will prevent you from having a pregnancy in the future. So a lot of people, that's sort of a hidden code inside of abortion care. Like if we really see someone that has tried to do this on their own, we're going to try and address that situation as quickly as possible to make sure that they get into a place of recovery and that the abortion is complete. We don't really start to dig into like, how did you do this and how did you start this? Now, if it turns into something where someone has done something a little bit more violent, it really does become a more complicated situation in terms of not being able to conceal what sort of activity has gone in that process. If you put something in your vagina like herbs, but you didn't think to put it in like a cheese sack or something like that, and you have floating herbs in your vagina, it's sort of you kind of make it look like it's obvious that you've been doing something. So those things are harder to conceal. So that's why I don't recommend that, because a lot of times those remedies, like if you don't know how to start them, you shouldn't. It's going to lead to a whole bunch of other issues and before you get to the point that you can achieve your goal. So I hope that answers your question.
Thank you. That was very, very helpful. The next question is from Karen, and Karen would like to know, are there, and I believe this is related to the portion of your presentation when you were talking about searching and getting misdirected to these predatory pregnancy centers. So are there any combination of search terms to help people avoid anti-choice propaganda and get straight to accurate information?
I would definitely avoid the word abortion altogether. I really believe the antis have co-opted that they've co-opted that word on the internet. I have tried to go through many search engines to see if I can get around it, and I can't. I really can't. And I think the phrase they have is abortion is bad. So I would not, like if you type in abortion, a lot of times it's going to pop up as abortion is bad. So I would never, if you're going to look for more information in terms of abortion, you cannot use the word abortion. You're going to have to use the word like family planning, pregnancy termination, use the words that I included inside of the slides, such as you can look up D and C, D and E. You can look at those two acronyms, D and C or D and E. You'll find out more accurate information that way. I'm trying to think of some other words that you can look up in terms of seeking stuff. But mostly, yeah, I usually use pregnancy termination, abortion, maybe abortion procedure in quotation marks. Be very clear that it stays like that, or abortion plus procedure. and then you'll probably find some more decent information that way. But any other way that you can sort of define what it means to end a pregnancy other than using the word abortion, you're more than likely you're going to find the information that you need. But using the word straight up abortion through a search engine, you're going to immediately get slammed with anti-choice information.
Wow. Wow. Thank you for the question, and thank you for that answer, Selena. So this question is from Catherine. And can you please tell us the difference between reproductive health care in the South and reproductive health care in the North? What is one major barrier or hurdle? Great question.
That is a good question. Thank you, Catherine. I would say the biggest hurdle is public funding for abortion. In 17 states, people have state-level Medicaid that allows them to use their pregnancy Medicaid or their ongoing Medicaid to actually pay for abortion procedures in these 17 states. And a lot of them are clustered in the mid-Atlantic all the way to I would say, the northeast part of the United States. There are several issues that are happening within the Southeast, and I will also lift up the Midwest because they're having the same struggle with not having public funding of abortion, in addition to having the struggle of having restrictions with the expansion of the Affordable Care Act. So that limits access to contraception. So you have two very big issues going on there. So in the South, the reason why I am the co-founder of Access Reproductive Care Southeast is that we are a reproductive justice organization that provides abortion funding to people in the Southeast, particularly in Georgia, South Carolina, Tennessee, Alabama, and Florida, as well as Mississippi, because there is no are traveling far and wide to get to an abortion provider. And that's another issue in the South, is that they're really spaced out. So 90% of counties in the Southeast of the states that I just listed do not have an abortion provider. You have a higher rate of abortion providers in the North, as well as you have the public funding option as well. So not only do people have to travel very far, people also have to pay out of pocket. And, you know, if you got to come up with rent and light money, you know, for you to pay for an abortion, it can be an extreme burden on families who normally have rent that's less than $500 a month, and an abortion is now like $575 average in the South.
Mm-hmm. Wow. Yeah, and thank you so much for lifting up the Midwest. As a Missourian, I am all too aware that we have one abortion provider in our state, and we actually serve a lot of people from other states. So I think sometimes it gets lost in the fray, but access is a serious crisis here. Thank you for that. So we have time for one more question, and this is a little tough. So this might actually not be something that is your area of expertise, but it might. So I'll toss it out there, or you might have some resources that you can direct this question to get answered through. So Kim would like to know, does an emergency room doctor have a legal right to demand you confess to performing a self-abortion? And does a patient have the right to refuse to voluntarily provide that information, or to provide you know, some other information, like I'm bleeding after a miscarriage or something? So basically, like, what are a patient's legal rights? And again, if this is not applicable, if you have another resource, that'd be great.
Say the first part of the question again. I missed it a little bit.
Certainly. Does an emergency room doctor have a legal right to demand you confess to performing a self-abortion?
No. You do not have to tell them. I know some providers will fight me on that, because, you know, they do encourage you to be transparent and they encourage you to be honest. But if you just present in the emergency room and you're just bleeding, you're just like, I'm bleeding and I don't know why, I would just stop right there. Now, if they find something in your vagina, say they found some herbs in your vagina, like, you know, you can tell them, like, you know what, you can tell them, like, I was just trying something to try and clean the area out. That's all you have to say. And, like, you know, can you get it out? Or you can just say like, I was worried. You know, you don't have to, you only can give up for so much so that you don't implicate yourself. But most of the times doctors are just so concerned about trying to get to the cause of the problem so they can get to the solution that they won't dig in your business in terms of what is going on. Now, my warning to you is this. 33% of hospitals in the United States are Catholic hospitals. So if you are
Yes.
actively miscarrying, they can refuse to see you.
Mm-hmm.
And Catholic hospitals are not afraid to let women die as a result of miscarrying. So that's
Very
another
true.
reason why I do not encourage self-termination, because you do not know where you're going to go. You don't know if that provider or that clinic or that hospital is Catholic or not. And if they find anything in terms of you miscarrying, whether you have evidence or not, they can refuse your care. I have had too many doctors tell me stories about them having patients die on them in a Catholic hospital because the Catholic hospital refused to intervene. So you have to understand that they have a right to refuse you care if you are actively miscarrying, whether they can prove it or not that you did it yourself. They
Right.
are, and I mean, it happened in Texas. It happened in Texas several times. So that's why I always caution against people doing self-induction, because if there's a complication, I cannot guarantee that someone's going to see you and treat you for it with the compassion and the sympathy and the understanding that is needed in order for you to get yourself back to health again.
Got it. Thank you. And I think that's a powerful question to end on. Selena, I cannot thank you enough for your work and your activism and for this fantastic webinar tonight.
Oh, well, you're certainly welcome. It's such an honor. And, you know, feel free to visit our website at our ARC Southeast. And we have like an info section. If you just have other questions, I'll be more than happy to email you back any answers or any resources. I'll be more than happy to do that as well.
Thank you so much. Again, thank you, and thank you to Kebe for proposing this topic and pulling together a fantastic webinar. We're going to go ahead and close it up because we love to be prompt at Reproaction, and we like to stay on time. So thank you to everybody for joining, and we'll see you in the streets.
All right. Thank you so much again.
Bye-bye.
Bye.